Check, check. Welcome, everybody. It's delightful to have you join us this evening. My name is Eric Siegel. I'm Director of Education here at the Harn Museum of Art, and I'm your host this evening, but I'm going to leave the introductions to Dr. Adam Kelly. This is a great exhibition to be able to share with you of the work of J. Frederick May, and this is a wonderful panel to deepen our understanding of the art, the issues, Jeff's experience, and of neurological issues that emerge from the intersection of art and medicine. So without further ado, I'll pass the microphone over to Dr. Kelly, and he will get us rolling, and he'll be moderating. Thank you.
Great. Thank you, Eric. And thanks to everybody for coming. This is, I think, a really exciting event. I think we've been really looking forward to this. I think this is some really interesting stuff. Can we pull up the other set of slides, like the set that I want to do? So, like Eric said, I think we've put together, I think, a really great panel of people here today, and I think we have a few questions that we'd like to pose to Mr. May and his wife Lisa, and and we'll get some input from our panelists, and then I think we'd like to open it up to the audience, and Mr. May is more than willing to address questions that people might have of him, and if it lends itself as we go around, we may take a look at some of his specific artwork and, have him describe, what he can about that and, what brought him to develop the artwork that he did. So I just have a couple of slides that I want to go through, not to be overly medical, but this is an event for medical professionals. So I do want to give a little bit of a background about some of Jeff's medical history, just so that we all have that as the background. And I think, from there we can, I think that'll open up the discussion a little bit more. Before we do that, I just want to make a couple of acknowledgments. Obviously, we're very grateful to the Harn Museum and the Center for Arts and Medicine at UF, who really invited Jeff and Lisa here, and then we were able to have this event more specific for medical professionals. So we're grateful for them. We did receive some support from the American Heart Association to help put on this event, as well as our exhibitors outside. So I want to thank Medtronic, Genentech, Portola, and Bristol Myers Squibb, who provided some support for tonight's event. I want to thank our physicians who are on the panel, Dr. Ken Heilman, and Dr. Brian Ho. Dr. Heilman, for people who don't know, is really an expert on cognitive disorders, amongst other things. So really interested to see his input on some of the symptoms and some of the experiences of Jeff. And then Dr. Brian Ho is a neurosurgeon who focuses on stroke and other cerebrovascular conditions. So we welcome their input on some of what's going on. And then most importantly, we're very grateful for Jeff and Lisa coming here today. So again, just a little bit of background, and you can certainly chime in and make sure I have the story straight based on what we talked about. But in 2011, really incidentally, as part of working up another medical condition, Mr. May was diagnosed with an ascending aortic aneurysm. And then in May of 2012, he underwent a surgical repair of that aneurysm, and really immediately, after coming to from surgery, he noticed some visual changes, which we can certainly explore exactly what he noticed. But I will just put up, again, for the people in the audience who are familiar with looking with CT scans, you can see here in the posterior aspect of the left occipital lobe, you can see there's an area of hypodensity here. I mean, you were anxious to look at your CT scan, so there it is. So this is educational for everyone in the room. And so that was in May. And then on this slide, you can see the results of his visual field tests, which were done in July of 2012, and then again in October of 2012, which really show a very stable right homonymous visual field defect. Sure.
It's not a black area.
Mm-hmm.
It's a faded
Okay. In 2015, Mr. May had another stroke, this time in his right parietal lobe. And this time he developed different types of visual changes, also developed some difficulty with short-term memory and a few other things, but those were the some of the main issues that we spoke about when we talked about his medical history. And then later that year, he underwent some neuropsychological testing and showed that there were some deficits in things like attention, concentration, and processing speed, at least relative to where he was expected to be prior to his strokes. So I think that was the very brief overview I wanted to provide. I think we'll use that as a background. I mean, does that sound pretty accurate? Okay. All right. Very good. So let me. Maybe you could start by telling us when you did come out of your surgical procedure in 2012, what did you notice? How did you know something was amiss?
I didn't know it was amiss. I just thought it was interesting that throughout the night when I was waking up, I was not intubated at the time, but I remember just coming to, and there was Lisa and a friend of mine in the room, and they would just kind of like float in like through this area and then give me some ice, whatever. And that was interesting. And then it wasn't until the next morning one of the doctors was interviewing me when they brought the breakfast, and I just asked would this vision thing. I didn't know it was from medication or what it was.
So you knew something was different, but it wasn't really particularly alarming or anything.
No, I wasn't alarmed in any way.
Okay.
No.
Okay.
Yeah.
Lisa, do you recall?
Lisa was alarmed.
Do you have insights about what you saw then, or?
I actually remember because everything had gone well the day before, so I went back to the hotel relieved because this was a year, waiting for this, and I walk into.
It's a big surgery, in case you.
Yeah, it's the NFL, and. I walked in that next morning, and the nurse didn't even look at me, and she said, "Well, we've had a different morning." And that's when we knew that this side was gone. And so that's when we're down to go get the CAT scan and revealed that he had had a stroke during surgery.
Oh, there was a lot of flutter after that.
Yeah.
Right. Did you notice anything different about him? I mean, like in terms of his interactions with you, or?
Oh, he was very much, let's heal the heart. Mm-hmm. I can see. I can move my limbs. I'm fine. Mm-hmm. And that's fascinating because he really wasn't fine, and he didn't really know he was fine for a long time.
Well, I realized I wasn't fine.
Yeah.
That's what. Because things just don't work the same, and it's kind of hard to come to that conclusion because I kind of looked like you wouldn't pick me for a stroke probably, and you just realize things don't work like they used to, and you just can't remember things, and particularly camera menus, like a digital camera menu. I'm sure everybody's familiar with that. And I was buying and selling cameras right and left because I couldn't remember any of the menus. I was like, one of these will work, But it was then I realized I have no short-term memory for that, and it doesn't work the same. And then so now I'm starting to pay attention to where all the deficits are for the first time, really. And that wasn't until that was pointed out to me by Dr. Stern in 2015. That was a big eye-opener for me. Yeah.
How about things like, even after 2012, that first stroke, things like reading and, watching television, things that, that are obviously very visually oriented. Did you have any limitation in those arees?
No, it didn't bother me. I was like working systems, and I'm moving forward. I'm going to, I'm not even thinking about it. Mm-hmm. I'm just, you want to have a stroke, I'm the one to get. This is the one.
Okay.
And it's fine, no problem. But it was just, you slowly realize that, you have lesions on your brain, basically, and it's not things just don't work the same.
Okay.
Yeah.
So I'm going to turn to our surgeon in the room to speak for surgeons. So I know you're kind of the neck up guy, but so Dr. Ho, can you talk about, again, what what might happen, from a stroke standpoint when someone's undergoing a surgery like this? And can you speak to what, our approach would be as a stroke team, for someone who's had a stroke right after a surgical procedure?
Well, as you mentioned, Adam, I'm a neurosurgeon, so I don't really operate on the aorta, which is in the chest. But from what I understand, when fixing an aortic aneurysm, you fix it by placing a graft or a covering that replaces the abnormal or diseased aortic artery. And when you do that, sometimes you have to cover some of the main arteries that come off of the aorta. And sometimes even if you don't cover them, blood clot can form on the graft. And that blood clot can fly off and go up into the brain, into one of the blood vessels in the brain. It may have happened while you were asleep under anesthesia, and so no one would have noticed or known that it happened until you had wakened. The interesting thing is that where you had your stroke, as Adam showed on your CT scan, is way in the back of your brain in a defined area and didn't involve the rest of the left side of your brain. Mm-hmm. So I think that would indicate to us that a blood clot had broken off, flown up, and then blocked off that very back part of the brain and didn't block off one of the more original arteries at the base of the brain. And otherwise you would have had, you said that this is the type of stroke that you want to have.
That's the way I was
Otherwise,
looking at it.
It would have affected other parts of your brain, perhaps speech or the ability to move the right side of your body. It's interesting, as a surgeon that treats stroke, the way that we treat stroke is we go up through an artery in your leg and we use x-ray guidance and we navigate little plastic tubes and wires inside of the body up to the brain, and we can extract the clot and pull it out and open up the artery. But we oftentimes don't do it for the very far out arteries in the way back of the brain because at that point the arteries are very small. It's a defined small area of the brain affected. We usually do it for the big arteries, at the original arteries that would affect the entire left side of your brain. So I think given your situation, if I were taking care of you, not knowing when exactly this happened, it was while you were asleep under anesthesia during surgery. The affected part of the brain is a defined area in the way back part of the brain and one of the small arteries, not one of the main arteries. I think we wouldn't have recommended the type of surgery that I do. What do you think, Adam?
No, I mean, I agree entirely, and I think, most people, a lot of the medical professionals in the room are probably aware of, the other option that we have for acute stroke treatments would be a clot-busting medicine called TPA. I think you would not have been a candidate for that because you had just had this major extensive surgery, and so the only option would have potentially been, one of these surgical procedures that Dr. Ho was describing. And I think, we always want to weigh the risks and the benefits, and I think in this case the risks probably would have outweighed the benefits. I guess for my own education, I don't want to get overly technical, would that even have been possible, for you to do anything with having just had that aortic procedure done and kind of needing to pass your devices near there?
Yeah, so it would depend on whether that graft or the covering that the chest surgeons use to fix your aortic aneurysm covered the vessels coming off of the aorta. But even if they did, we are able to come in through the arm. So we could come in through the arm and then go up your neck into the brain.
Okay, great. So can we talk a little bit about your career even before 2012? Mm-hmm. So can you describe some of the work that you were doing as a photojournalist, and I think you were making some documentary films and other things. So can you describe what you were doing before, and then were you able to work between your stroke in 2012 and then what happened in 2015?
Okay, I was a newspaper photographer for many years. That was my profession, newspaper photojournalist. and I probably have done more than 10,000 different assignments, literally. But the where did I go? I lost it, right?
Then we both, well, actually we met.
We both are journalists. Yeah, we met in the newsroom. So,
and from that we started a production company. So he, of course, was the filmmaker and running the cameras and all of that, and worked for nonprofits and educational institutions.
we did
and
industrial filmmaking.
things like that. As he was asking you what changed with the cameras and filming between 2012 and 2015.
What happened after that? The 2015 stroke is where it all became more apparent. But what was the part about the
Between 2012 and 2015.
Yes, I attempted to work. Yes, I was. In fact, thought I was going to be great doing it, and I worked in several jobs, and I was not very good. I mean, this is just a fact, and I'm having to work harder, and that causes more stress. And I had a stroke in 2015, and that's when I had my evaluation, and it opened some doors for me. But I was still just thinking I was fine, and there's no reason why I can't do this. I can't see a reason, but there were reasons.
Right.
Just not very apparent to me. And I was not a person who was, I just thought it was fine.
Okay. So let's talk about the 2015 stroke. Or let me take a step back. So between 2012 and 2015, some of the hallucinations and some of the some of what we're seeing in the room here, you weren't really having any of that between
Not at that
2012
time, no.
and 2015.
Oh, I only had these hallucinations that you see here in the first 18 months. And they were the animated faces I would get in a situation like this, just talking to somebody. There would be like this face, and it would be animated. And you could show that clip and it would do it.
The first 18 months after your 2015
Yeah,
stroke.
they came and went.
After the 2012 stroke.
2012
really?
stroke.
Oh, okay.
That's when I got
Okay.
these. But then they eventually dissipated. They were very crude animations that would appear out here. So the only thing you would see are the dark areas of the prints, not what's behind them, just the dark areas. And the images or the faces, they share these similar traits. And they're not, if you look at it, they're not pictures of faces. They only suggest a perception of a face.
So you had these for 18 months between
Off and on in the right, and then they follow
in the area where your vision was
area,
blurred.
very prominent in when I would engage with someone, but they faded away. And then I brought on this new group that is in my far peripheral, and when my brain is very tired, which happens very easily, they will start. They will start to congregate over here like a group. And they pay no attention to me whatsoever. They're very brightly colored for some reason. Orange and pink is a theme that runs through them. But they don't pay attention to me. They don't look at me. They're kind of faceless, but they're just kind of here. And if I look at them, they go away. They're gone. They're gone. And the same would be these. As soon as you concentrate on the face being there, it disappears. So you have to pretend like it's not there to look at it.
See from
Oh yeah, this is my crude interpretation of how they would animate. I'm going to put it together finally in a film, but it's they would dance like this. So they're sharing these individual traits that are just a suggestion of the face.
Were they threatening or scary or
No.
bothersome? You just noticed them?
No, they were just there arbitrarily and not paying any attention to me. They were engaged in whatever they were doing. And I was not even a part of their thing, but they kept showing up.
Okay.
Yeah.
And so you had those for 18 months, and then they went away. Okay. Could I turn to you, Dr. Heilman, and can you educate us all a little bit on, some of the reasons why someone might have this, and maybe talk a little bit about Charles Bonnet syndrome, which I think was the diagnosis that you were given.
Okay, well, first of all, let me start off by saying that when somebody has a disability and it enhances their productivity, they're a hero. you're a hero. Okay?
Thank you.
That's the only kind thing I've done this year. Okay. So the question comes up about hallucinations and what is the basis of it. Before we talk about that, in general, one of the founders of modern neurology, Eulens Jackson, said when you have damage to the brain, two things happen. You lose some functions and other functions are released. Okay? And that is a really very strong rule. And in some ways you're fortunate because when people have left occipital infarctions like you did, sometimes they can lose the ability to read, as we talked about, and you're reading fine. Sometimes they have problems naming colors, and sometimes they even have problems naming things they see. And the reason being is generally is that you're seeing, okay, primarily now with your right hemisphere back here, and your speech is up here in your left hemisphere, and there's a connection called the corpus callosum. But that corpus callosum, those fibers have to go in to the back part of the brain before they come up to the speech areas. So if you damage that cable, okay, yes, you can see things on your left, but you can't get them to your language areas. And so you have those problems. So you are indeed fortunate because you can do those things. So you have some of those cables still intact, okay? Now, the next question comes up is about hallucinations. What is hallucinations? I often ask people in my clinics, what's the difference between hallucinations and imagery? Does anybody in the audience want to answer that? Anybody here want to answer it?
I read your book this afternoon, sir.
Okay.
Because I can still read.
Okay. Well, it turns out that it's intention. Okay. So when you image, you have the intention of imaging, but when you hallucinate, there is no intention. So what brings the image up if you don't have the intention? And basically, there are several things that can bring it up. Now, one of the things after I heard you were coming here, like many neurologists, okay, we're historians. And so I went back, because I've heard about this before, and went back and got the literature, and there's some slides there. We don't have to show them. But one of the stories, okay, is a little journal article here by Monroe Cole, a very famous neurologist who also had a stroke. It's not very clear, but it's right there. You can see it in the left occipital area, right over there. And if you read this article, he's describing many of the things that you had. And he describes, and I wrote in this article, but I'll give it to you. I apologize. Yeah. But what he also mentions is that there's a long history of prior descriptions of this. So this is actually a well-known syndrome to some people, not all. Very, very small group. So the question then comes up, okay, why are you hallucinating? Okay. Now, one of the major causes of hallucinations is when the brain is firing spontaneously. So it spontaneously fires and erases the image. And a lot of people said, well, that must be happening, but there's no evidence that any of these patients had any kind of epilepsy going on, because epilepsy can do it, okay? So what is the mechanism? Nobody really knows, but what I have posited, okay, and this is just a proposition, is that in general, okay, we have the conscious awareness of seeing something. We're aware we see something. And we have two systems that can allow us to see something. We have the eyes that allow us to see it. So think about a television screen or monitor. And there's a camera. So the camera goes right into the television, and you're showing it around, and you can see the images that the camera is looking at. But there's also a videotape machine that comes into the camera. Okay, when you turn the tape machine on and the camera off, you see images, right? Okay. In humans, because of survival reasons, we always have a priority. The camera comes first, okay? If you want to image something really well, what do you do with your eyes? Normals? You close them. You close them. Why? Because you want to shut down the camera, okay? What happened to you is you didn't shut down your camera, okay? That clot broke one half of your camera. And when that happens, it releases the videotape machine, and the videotape machine is putting all these images up. Okay? Now, what it turns out also, that when you look at these images, they're very creative. Do you want me to stop here or keep going? Okay. My wife's going to fuss at me and say, you took too much time. Okay. Well, it turns out what's really interesting is that a good friend of mine, Bruce Miller, who's a neurologist in San Francisco, he had several patients who had a degenerative disease of the left hemisphere, where the left hemisphere started losing nerve cells, mainly here in the temporal lobe. And what happened was these people developed into wonderful artists. Okay? So there's another point about that. Each hemisphere has to supply the other hemisphere with information, but each hemisphere also inhibits the other hemisphere. So each hemisphere can do its own thing. Okay? Are you with me?
Yeah.
Okay. So if it didn't do that, then we would always be doing mirror things, everything we did. Okay? And the same thing goes on. So one of the positive things, okay, is when you damage one hemisphere or the connections, what you do is you release the other hemisphere.
That's why it's called visual release hallucination.
You got it. So you have two things going on here, okay? You have the ability to image, okay? And you've been released, okay? And that enhanced your artistic creativity. So even though you've had some damage there, okay, in a way you've been blessed because it brought out something positive. And because you're a hero, you went ahead and utilized that to increase your productivity. So that's the big picture. I can answer more detail, but my wife's going to say.
Start cutting us off. So, I mean, that was incredible. To put it, to kind of really, I think, take something that seems very complex, but I think, put it in I think terms that we can all understand. I guess one of the questions I always have, and Brian, you can speak to this too, and other people in the audience can chime up. And we see a lot of people who have left occipital strokes. I mean, this is not. I mean, I don't want to make you sound like you're not unique in any way, but this is not an uncommon scenario. But we don't see lots of people, whether it's because of stroke or because of a surgical resection that has to be done. We don't see everyone develop these types of hallucinations. I don't know what's your experience with how often patients, again, whether it be stroke or an aneurysm or a surgical procedure, how often do you have patients who report findings like this to you?
Rarely, but, in listening to Dr. Heilman's explanation, I can only think, in your prior career, you had done 10,000 projects and had produced all these photos and images, and that was your life. And so all of that is stored in your brain, and when released, that's why I think you had these hallucinations, whereas somebody with a different occupation or different life may not have had all these images or 10,000 photographs and such. So,
I agree with that in part, okay? But it turns out that there's a disease, almost like an infectious disease in medicine, which almost like syphilis is destroying our brains, and it's called RVUs.
RVU.
Yes, right. RVUs, relative value units. Right. And you know, if you don't get to see a patient, it takes you more than 8 minutes. You have an administrator call you up and saying, "What the hell are you doing?" Okay? And the question comes up here is that very often when patients have hallucinations, guess what? They're not going to tell you. We have lots of neurologists and neurology residents here. How many of you in your reviewer systems ever ask a patient if they have hallucinations? Nobody. One. Okay.
Oh, we got another one.
Okay.
Great.
But-
Kind of
Okay.
timidly.
But
raising your hand.
the point about it is that people don't offer this.
Sure.
This man's a hero, but not only did he offer it, but he made it creative. Okay? There's lots of things that patients have that they don't tell you about. And I can show you many of my papers where I've described things like loss of comprehension of emotional prosody, faces. I can go on and on and on. None of those patients ever told me about those problems. Okay? The reason we have memory clinics is because people don't have concepts and don't want to bring those things up. And with the RVUs, you're not allowed to bring them up. You are not. You'll be fired. It's a bad virus.
I'm going to take the microphone back.
Could I add to that? Just from my personal experience, and that's all I can ever speak is my personal experience, is that when I first brought up the hallucinations, it was to Lisa, and when we were walking around the ward, and we go all the way around, I was at Cedars-Sinai in LA, and I was describing to Lisa what I was seeing on my right side of me. There was all kinds of stuff happening. And I told her, I said, "Don't tell anybody or I'll never get out of here." Because I'm just trying to get out. Okay, I figure at this point I've survived a big surgery and a stroke. Yeah, I'm good. Let's go.
Yeah, I think, Dr. Howman, you made an excellent point about how, we have, as physicians, providers, we have to be willing to ask that. We have to demystify asking and make sure that we create an environment with our patients where it's okay to have people tell us things that they're insecure or afraid or uneasy about. So let's focus on your art a little bit, because that's why we're here. So in 2015 you had the second stroke, and then what finally prompted you to say, let me start to describe my experiences through art? I mean, what made you finally decide to do that?
It was more of evaluating a body of work. I work on all types of imagery all the time, and I started this work on an iPad, one of the old iPad ones, and the idea was it was just a simple thing to use. I kind of underestimated my recovery, which was during the summer, and it took a lot longer, so I was kind of working on this iPad and doing things. I would glitch imagery, anything. There's tons of apps you can get. And it wasn't until about 2015, and after I was going through my evaluation, and I started evaluating my bodies of work that I created. And these images are probably from maybe 8,000 different images, of just apparitions that I would create. But they don't look exactly like this, but they're close. And it wasn't until I saw them as a body of work together that I could make the connection. I went, oh, wow, there is something here. And that's when I started exploring that. And I was going, yes, those are the black marks, and I can see the shared. For me, it was the shared attributes that they would interchange, and I went, wow, that's like actually there. And the neuroscientist Joshua Sariana at MIT, he had pointed it out to my subconscious that I had been working on these, and I was like, really taken by it. So,
Did these come back again after your second stroke?
No, they haven't. No, I've seen some odd shapes and forms that are just black, and they just kind of fall into nothing. But not to this extent. It wasn't the animated faces. These were very animated and like they were trying to fit together, and they just never did.
But now there was the interesting thing in walking. He does a daily walk.
Oh,
and
right.
With the jogger.
That's true.
Explain that, because that's fascinating.
Well, this is two different things that it seems my brain gets kind of prompted by different things. So if I walk around the neighborhood in which we live, it's in the morning, the sun's at my back. Now, no doubt, whenever I'm walking, there will be somebody who will run by me. And as I see them, their shadow precedes them as they come by. Well, whether it occurs or not, I will see the jogger's shadow, and I may see it 2 or 3 times as I walk around, and I go, and there's no one there. And it's just a reoccurring shadow. It replays itself. Yeah.
If I can say something.
Of course.
It turns out that I'm not going to examine you now, but there's a neuropsychologist who started in Arizona, ended up at Oxford, Larry Weisenkrantz, who had patients who had hemianopia, like you. And he wiggled their hands and said, "Can you see my hand wiggling?" And they would say, "No, I'm blind on that side. I can't see it." "Can you see it moving?" "I can't see your hand." "Wait, it's wiggling again. Can you see it?" "No, I can't see it." "Well, point to it. It's right there."
Wow.
Okay? So it turns out that you have 2 visual systems. You have a visual system that lets you see forms and colors. And you have a second visual system that allows you to see movement. Okay? It turns out when you have strokes in your occipital lobe, like you did, you injure the one that allows you to see shapes and colors. It does not destroy the one that allows you to see movements.
Oh, wow.
Okay? And that's called the collicular system. And so a lot of people have noticed exactly what you did, okay? That they can see movements. Now, it turns out what's actually interesting is that when we try and go spearfishing, did you ever try that? We suck.
Don't try that.
Maybe I should speak for myself. I suck. And why is because I'm using the occipital system. These birds come flying along, dive down into the water, come up with a fish. How the hell do they do it? They use that movement system to catch the fish.
Wow.
That's very interesting.
Wow.
Yeah, I mean that's a good point. Absolutely. So when you started creating some of the work, I mean and I'm not an artist, so maybe I'm trying to.
Everybody brings their own story to it.
Yeah. So I mean, were you trying to? I mean, did you find it that you were doing it as a therapeutic experience? Were you trying to explain what you were seeing to an audience?
There was no intention. In my original working on him. It was just sheer aesthetics, just working on faces, distorting faces, doing this. It was sheer aesthetics. No other reason to really do it. And I work on other types of digital art as well and different things. So it was just another thing that I kind of worked on. It wasn't until I really saw the body of work, and I'm actually going to have future ones that show kind of some metamorphoses of the faces. Most of these faces originated from either mug shots or photo booth images. And I really don't want anyone to know what they started out as, because that kind of jades the image then. Because there's supposed to be something you don't know what it is. And if there was any relation to any person in any way, it would totally ruin what it was, because you wouldn't know. So I don't show where they actually started. I just show what afterwards. But that's how that's where all the pieces came, and they're all from multiple pieces. And I do make sure that I try not to have the image represent wherever the original came from. So there is a neat little trick you can do with Google Images where you throw your image into and see what it comes back as. So I'll throw these into Google Images, and you just say search for this image, and if it doesn't come back with the face where it started at, then I'm doing good.
Okay.
Yeah.
Could you ask him what he sees here?
Sure.
Ask him what he sees. What do you see?
What do you see here?
What do you see?
A lot of B's. It's an A, A and B.
Okay.
Yeah.
So, sorry. How long does a piece like, one of these individual pieces take you to do? So let's take maybe like the second one in.
Right.
On the right. From
that
the
one
right.
there. What that is, it's the result of, it starts on that started on an iPad with a glitch program. I think that might have been Decimate. There's all these glitch programs you get that are just free. And they just mess up images. They go into the internal workings of the code of the image, and they corrupt it. And I've done this for a while, so that wasn't really new to me, that aspect. But I got to where the faces would replicate. So in those programs, when you like something, you can just save it, and that's kind of a preference. So I took kind of a pride in influencing the algorithm. So the more things I would like I like the way that's coming out, then that's moving my taste into where it is corrupting the image. So I was able to gain a lot of control. So some of these there may be 400 or 500 of these, and I keep maybe 60. And because there's a lot of bad ones. That just don't make sense or whatever, and they just weren't appropriate, and I edited it down to these. But it actually does take a lot of time to actually create the image itself. Now, when they're done, it's still a digital image that is on a computer, and I really felt the need to get it from a digital image. I could print it as a digital image, but I wanted to bring a photographic feel to it. And that's where I decided to use the cyanotype process. Is anyone familiar with the cyanotype process? Well, it's basically it's called a sun print or an iron print, and it's what blueprints are made of, and that's why they're blue. And I found that was a really good process, which just uses water. It's really easy to do, and I had a lot of I think aesthetic choices I could make with it. And so I would make the cyanotype, which becomes, as you see them there, they actually look exactly like that, but they're about this big, and they're one of a kind, and we keep those in a safe. So, and then these prints are made. We use as a plate to make these canvases from. Is what we do.
But add on. So you did the cyanotype, which turns it blue.
Yes. Yes. That's correct. They're bleached then. After they're not blue. They're all blue. They look blue, and then I bleached them, and then I toned them with tea, like just tea you drink, and that gives the different kind of a duotone look to them, which doesn't give just a straight cyanotype look.
And one thing, whether it is of interest or not, what you like is the combination of the analog
well,
and digital.
they start off as a digital image on a digital device, and people go, well, it's just a digital image. It's just, it's just pixels on there. So, wait, where was I going with that?
Well, that your background is
Yes.
analog.
So,
it's photography from the 70s.
It is. I'm a film shooter. That's where most of my career was based on film. So I keep getting lost. I'm sorry.
That's okay.
Yeah, I see.
What you like is that
The
back
digital,
and
yes.
forth of the digital and analog, and how you see it in these images is you notice kind of like a square almost around a lot of these images.
I know. I can get up and go point at it.
Get up and point.
I will do that. Is it okay if I get and point?
Go. It's your show. Here, I'm going to bring you one of the microphones.
Oh, okay.
When these are made, there's a digital, this is called the rebate edge. You see negatives and they have like a black border around. That's called a rebate edge, and that's the clear edge of the film. And I originally put just a digital made one that comes in Photoshop around them for the preliminary proofs of them. But what I decided when I made the cyanotype is I could paint and I could manipulate that digital border with the analog border that's created. So for me, the best part was that this side, it looks like this side of this line is made by a computer. And this side of the line is made by my hand. And you can't tell the difference in the two. And I just love the merging of the two technologies. This process, cyanotype, was created in 1840. And it's being used in conjunction with an iPad with my goal in bringing the two together. So, does that make sense?
Very, very cool stuff. So, do you have other individual things while we have you up?
Any questions you have, I'll answer.
I was going to say, so maybe in a minute we can open it up to the audience. So, let's go ahead and sit back down. So, Lisa, I have a question for you. As he's gone through and has done more of this artwork, have you noticed any changes? Anything, from your perspective, from the partner's perspective in this? Have you seen any?
You know what it is that is the lovely. What it is that's lovely is that it's not that you don't care about the assignments that you do at a newspaper or television station or in documentary work, but this is him. You're actually seeing him, and before the stroke, you didn't see him.
Well, that's true. Most of my work was done in a commercial or assignment capacity, in which I'm a channel for someone wherever it's going. This is probably the first project I've ever done that's just about me. Yeah, that is true. Yeah.
Great.
And that he lights up in a different way, and that's like a gift.
Yeah. Well, I think to Dr. Heilman's point, it allows you to kind of release again some of this creativity.
Yes.
And
I understand that now.
And I think, Dr. Ho mentioned it, and when we spoke on the phone, we mentioned too, on the one hand, the fact that this stroke affected your vision, as someone whose life was about vision, you could say, well, that's a setback. I'm so dependent on my vision, but because you're so, well developed from a visual standpoint, more so than probably anyone else in the room, it allows this, when you are released, it allows you to do something, dramatically different than certainly I could do, or that probably many people in the room would be capable of doing. So,
and in all fairness, I really just followed the process. It was really, it led me along. I really never really pursued it, but it kind of just led me along, and I just followed it.
Great.
That's all it really was.
Okay. Are you up to taking some questions?
Sure, absolutely.
Okay.
Anything you want.
People have questions.
Tell you how much my medical bills are.
Do you need?
What I do when you make the first, when you make a cyanotype, or really any original print like that, a photographic print, it's a contact print, and then you develop it, and it's blue. And what I do is I overprint them, so then I will bleach them. Then I use what's called washing soda, and it's a very common household thing. And you just put a little bit in, and it starts to bleach out the blue, leaves a little bit of blue, which I want. And then I use 3 packs of oolong and 6. What was it? 6 of those other teas.
I don't remember.
Anyway, I put them in and get it really hot.
You just don't want to give your secrets away.
Well,
I understand.
I can't remember. And you put it. I do it and let it steep, and it gets really. It's warm. I use it when it's warm, and then you put the prints in probably about 5 to 10 minutes, depending on how much you want it to change. It starts filling in. See, what happens when you bleach it, all the color goes away in the white area, so it becomes just white. And when you put the tea to it, it kind of calms all the paper fibers down, and they all kind of lay down then, and they become the tone of the tea. So all the highlights are the tone of the tea, which is whatever color it is, and then the base is blue, which is the sienna type. So it's a duotone it makes. I do, yes. In our home, we do, yes. And I have
Basically, the house.
the house is, yes. My living room has a 44-inch printer in it. Yeah. So, yes.
I'm kind of curious, as you said that you first noticed that your interest had gone from commercial to now creative. Do you think this change has now affected your everyday life? Like things that you see that before now, flowers or decorating a house, that you see a creative side to it that
Yes.
you didn't do before?
Absolutely.
Does this affect other aspects?
Yes, and that's a really good question. I tend to look now, the more I have learned about this, I look for the glitches in my site. And it becomes kind of an obsession. I kind of look at it, I try to make it happen. It's something I go out of my way to do, and I didn't do that before, obviously. But so I look at those, and I can catch them. They're kind of interesting. And I'll go and I'll tell you, I'll be in the darkroom, I got it to do it again, you know. And I did a thing in the darkroom where I would light a lighter, and I would let me see the lighter, and then I wouldn't light the lighter. And then I'd wait for the darkroom to light up from a flash from the lighter that wasn't lit, and it would. And then it would do it like about every 10 seconds, and it would go boom. And it even light the walls and everything as a memory. And that was just amazing to me, that I could prompt it by going like this without the lighter, and it would prompt. Does that make sense, you guys? Okay.
So for Dr. Howman, so should we be doing this more with our patients? Should we be, when you see someone with a vision problem, or Brian, when you see someone with a vision problem, should we be, I guess more, one of the things that we often struggle with is that we don't have a great paradigm for visual recovery like we do physical therapy when someone has weakness. But, should we be more, I guess, open and more proactive in encouraging our patients to explore, creative aspects, whether it be photography or other art? I don't know. Do you do that routinely, or do you do that routinely?
We encourage them to do art. It depends upon the patient and it depends upon the patient and the situation. I think again, one of in addition to the RVUs, one of the big problems now is that when people are assessing cognition, they'll do a mini mental status exam or maybe a MOCA. And what happens, those are very constricted examinations, okay? And I was actually trained in a school where you don't do those things, okay, where you speak to the patient, you try and find out what's going on, and then you evoke stuff. And based on that, a lot of the time we should be speaking with patients and telling them, okay, this is what your disabilities are, but this is some possibilities that you can do to enhance your life. And I think that's a very, very important point that I always try to propose and teach. And there's lots of other things, like one of the reasons I asked you to give that little test about the looking at, that's called a Navon figure. And it turns out, for example, it was interesting because you talked about analog versus digital. Mm-hmm. Well, people always, when they divide the two hemispheres, they talk about the left being language and the right being visual spatial. That's incorrect, actually. It's partially correct. But it turns out that the left hemisphere, for the most part, is the digital hemisphere. and the right is actually analog. So spatial skills are analog, melody and music, which comes from the right hemisphere, is analog, mathematics, reading, writing, speaking is all digital. So the question comes up both ways. If somebody has damage, you encourage them to do the things that are released and they can do, but you also want to have them practice the things that are disabled so they can get rehabilitated for that.
Well, I remember when he was still in the hospital, and the doctors were saying, because I guess in 6 months you will know whether it's going to come back or not. And they were saying, find, like, where's Waldo? And force yourself to find Waldo. Look into that blind area and all of that. And I am assuming that is to try to, if it's going to come back, encourage that.
Well, let me have that piece of paper. We'll do another little piece of examination here, okay? Okay. No. Okay, put that directly in front of him. Mm-hmm. No, directly in front of him. Get your body straight. Okay, give him the pencil and have him find the middle of the line.
Draw me a line.
No. Yeah. No, just make a little mark. A little mark right in the center, dead center of that line. Dead center. Okay, let me have it back. Okay. That's exactly what's happening. Okay, so, let me explain. Okay. No, he's really dead on.
I do that all the time. That's why I do that.
Well,
you see all the pencil marks.
Okay, so let me just tell you what usually happens.
Let me tell you what you should have done.
It was probably a bad day.
He's just different. Okay.
I have something that might go with that.
Well, he is actually perfect on this. Okay? But let me tell you this, okay? Is actually, even though I say he's perfect, okay, it turns out if you go home and you do lines like this and make a mark, you can all have fun doing this, then fold it in half, and it turns out almost all of you will deviate a little bit to the left.
Really?
That's normal. In other words, your mark will be too far over to the left, okay? Okay, and I don't want to get into all the reasons why, but that happens. But if you have a right heminopia, you're allocating more attention to the right side, and so you move it over toward the right, okay? And he is actually a little bit moved over to the right, because most people will have it a little bit over to the left.
Can I add to that?
Yes.
An instance I've noticed is I collected a whole bunch of ballistic glass I had got together for an art project. I wasn't sure what I was going to do with it. I just wanted to get this glass together. And it was a whole bunch of it. And it was samples that people who sell ballistic glass have. So I got it on eBay. And I said, okay, we should do something with this. So I have no firearms myself or anything. And I said to a friend of ours, well, you have some firearms. Could we go shoot this up? This glass and see what happens, and then I can work, take it to another level. So we went out to the desert up near Joshua Tree, and out there you just drive 5 miles out of town, and you can shoot a firearm anywhere. And we got out there and put all this ballistic glass out, and he had a very sophisticated weapon that had this thing you just put the red thing on and on. I don't know much about guns. Even with that, I could not hit the glass with her. Lisa was like a star with it. I didn't hit any of them.
Which one were you missing?
I couldn't tell, but I also found, now another thing is I've had the hardest time with my table saw in pushing a sheet through it straight. But then I found if I go to the side of the saw and move it this way, it goes straight. But when I go this way, it doesn't go straight. And I have this parallax problem with cars trying to run into us all the time on this side. So Lisa has me sit in the back. So, and just because I drive her crazy with it all the time. Is that what?
What you're saying is what happens is basically when you have this, you learn in some way to allocate your attention more to where you're injured. So you can't see toward the right, so you allocate more of your attention voluntarily, okay? Not consciously, but toward the right, so you can compensate for that disability on the right. Okay.
The other part is now I'm a little off topic, but I'm wearing yoked prisms, and they've made a significant difference in my life. They calm the brain down, which is, it's hard to describe what that is, but it does. It calms them down. It calms it down, and I probably in a kinetic field test, not a static, but a kinetic one, I think I get about 20% more peripheral with them on.
That's what we talked about, the kinetics.
Yeah, and the other part would be that, however, with these, because it's optical and it's bending the light optically, I get less other hallucinations, but now I have compounded with kind of optical hallucinations that the glasses bring into it, which is kind of interesting. So,
do we have more questions from the audience? Oh, I think that was just blank paper, in case we want to do more testing.
yes.
Gary.
Thank you very much for sharing that.
Thank you for coming.
Just wanted to thank you for sharing your story and the panelists for their great comments. Just a few points that I wanted to ask. First of all, to you, just a clarification. Mm-hmm. So the images you see here, you created, right?
Yes.
To what extent do they represent what you actually experienced? Because I'm a little confused about, you had one stroke, a 3-year period passed, you had these hallucinations at that time.
Yes.
And then you had another smaller stroke in the same hemisphere, and these have disappeared.
Other hemisphere.
Or the other hemisphere, okay. And then these disappeared, or you don't have them?
No, they were already gone by that time.
Oh, I see. So
yes.
they self-resolved even before you got... Right.
I had different ones. I had the big peripheral groups of people at that point by the second stroke, and they're still here. So, but they just don't come as often.
Right. So these creations of yours, how close are they to your actual experience of what you would see?
Well, I would say they're not forensically accurate or, like a pathology accurate. I mean, because I do have a good amount of aesthetic license I've given them. What is truly accurate is the shapes and forms. Would be the glasses, the hair, the lips, the eye, that keep repeating themselves as disjointed pieces that don't really form a face, but they make you think there's a face. There isn't really a face. It's just they're really just forms and shapes, and that is really just the dark part of it, and that's pretty accurate as to what I would see, kind of. But it would be changing all the time.
Like the animation where the faces were changing?
Yeah.
Like that is how they actually moved.
But no, I did put a great deal of creative license in it, yes.
They're very stereotypic, the tone, the geometry, the things that occur in them, they're always faces, like they're never animals, they're never things, right?
Right.
They would always be faces, human faces?
They were trying to be faces.
Right.
Yes.
Yeah, whatever.
They were trying to be faces. Yes.
Right,
It's
right.
more. Has anyone ever seen Monty Python? Okay, the opening, they'll have like a really bad animation sequence that Terry did on that. It was like those animations. It was just real, like the jaw just would go like that, literally. It was literally like that. It would just, they're just moving in a very crude animation where you're just motion control, where you're just pulling down it and then put it back up, take another picture and put it down, so it just goes like that.
And the same hue, the grayish and the same colors always. I mean,
no, actually they were more of a black, the actual moving shapes and forms, so more of a black shape. I decided to go with the duotone because it just really kind of fit. I did put a lot of creative license in it, of course. That was the original point, but it just turned out that how representative it really is, fairly representative. Now, I don't know. I can only speak from my experience. I've read about other people's experiences, and other people have where they're very concentrated on teeth. I guess they have big teeth, stuff like that. I've read, but I never had the teeth.
So can I turn to Dr. Hellman, and then I'll pass the mic on?
Probably one more question, because we do have to wrap up. So, Gary, we better be good, because this is the last question of the night. No pressure or anything.
No, I've got to think really hard, and I'll waste even more time. So, Dr. Hellman, so can you just comment on the fact that there's this recurring theme? You talked about a videotape, right? And obviously we have millions of visual experiences in life, right? So why should it be, in your view, that when something like this happens, the same thing occurs again, or very, very similar? And if I can just continue the thought a little bit, they seem a lot like complex migrainous auras. We have patients with seizures, and you said this wasn't an epileptic phenomenon, but we do have patients, and I've encountered patients with seizures who actually have this, and they may have it in just one hemifield, and they have one normal hemifield, and then they have a distorted other hemifield, which represents their epileptic hallucination. But it's always something that's fairly recurring in terms of the theme, in terms of form and colors and so on. So if you can just comment on that.
Well, you ask a good question. And again, it turns out that if a patient has a stroke in the left hemisphere, if they have a visual problem, where they can't recognize things, it's usually objects. If they have a stroke in their right hemisphere, in the ventral temporal part, the thing they can't recognize is faces, people's faces. And that's a disorder, as you know, called prosopagnosia. So he has a left hemisphere infarct, and he's releasing his right hemisphere. So what is he releasing? What becomes hyperactive? What's in the right hemisphere is the representation of faces, And so that makes perfect sense of exactly what he's doing. Now, one other thing that...
Sorry, can I just counter that? I mean, this was in the area of the world that you would see this in would be on the blind side or on the normal side?
About right here.
The blind.
Right, it'd be about right
side.
here, where I can't see my hand.
So if he was releasing his right hemisphere, wouldn't he be seeing this in his left?
That's a different thing, is where he sees it, Now, what I want you to do, remember I said to you that with the line bisections, they deviate over the right, So I want you to count on your fingers the different pictures which are deviated different ways. We're going to do a little experiment. The first one, that paper is to the right. That's one right. Second one is left. Third one is left. Fourth one is right. Fifth one is left. Next one's middle. Next one's middle. Go on the top here. To the right. On top right. Bottom right. So that's 4. Bottom middle, 5. Let's go over here. That one on the right, that's number 6. That's kind of toward the right. 7, 8, 9, 10,
You're just showing off now.
11.
It is generally toward the right. One thing I want
Showing off.
One thing about that, though.
I think I got to call my friends from Brooklyn.
You were going to say that?
I did. A woman came to my show in Santa Ana recently. She's a makeup artist, and she has facial blindness. And she was really emotionally taken by it because she says this is like the faces she sees. And it's been a real problem for her because she does makeup of people close up, and then she sees them, and she doesn't remember them, and they think bad things of her and so forth, think she's socially awkward or whatever. And it's been a real problem for her. But she brought that up, that these faces. Now, I have no experience with that. I didn't know if there was a similarity.
Well, again, as I said, we talked about the concept of release,
Right.
And it is the right hemisphere toward the back okay, that actually stores faces, okay? And the idea that we brought up in the beginning conversation, okay, is that you're releasing those. That's why you're having hallucinations. So if you're going to release something in that part of the brain, what is the most likely thing you're going to release? The thing that it stores. What does it store? Faces.
All right, I think, well, I'll just say something, or unless, Eric, you want to take it away? Or
I was going to say that we have reached the end of our evening's time, but the conversation does not have to end, because tomorrow we have another panel here at the museum. Some of the same panelists who you're speaking to tonight, including Lisa, Jeff, Dr. Heilman, Dr. Kelly will be able to join us, as well as Dr. Polifka. And so we invite you to come back for further discussion. 3 to 5, there will be a discussion and another reception. So thank you so much for being here this evening. And thank you so much to Jeff, to Lisa, Dr. Heilman, Dr. Ho.
Thank you all. Thanks for coming.
You, sir. Great to meet you.
Great to see you again.